stake, and what are we all in for potentially with this COVID wave? With me now is Dr. Jane Morgan. She is a cardiologist and executive director of the Piedmont Healthcare COVID Task Force. So good to see you. You know, I say what we're all in for because, I mean, if the president gets Paxlovid and seems to be doing well, and then he now goes into a negative test, even though he doesn't seem to be exhibiting any symptoms, it has everyone wondering, okay, so who is the best candidate for Paxlovid, or is this normal, this kind of outcome normal for any and all of us?
And so that's such an excellent question. When we look at the Paxlovid trial, it was done between July and December of 2021. So this was really before Omicron came into predominance within the United States. 2,245 participants, all of them unvaccinated. And so here we have a drug that's approved under emergency use authorization, but we are in a different era, right? These variants are moving quickly. So the drug is being applied during an Omicron surge and mostly in vaccinated people, whereas the trials were done in unvaccinated people during a period of time when Omicron was not surging. Those trials ended in December of 2021. So there was a 1 to 2% rebound rate in those trials, but that may not be applicable to real world experience where we are now.
So does that mean there might be ultimately some adjustments in Paxlovid, just like there are some adjustments being made for the COVID vaccine because of the new variants?
And it really could be that 5 days is not enough time to really suppress this virus for Paxlovid, certainly not in the midst of this BA.5 surge. And it may be that that time frame needs to be extended more to 7 or 8 days. Clinical trials will tell us that. What we do understand is that the virus is not completely suppressed in a certain percentage of people, and we see this resurgence. Clearly, it's probably anecdotally higher than the 1 to 2% that we saw in clinical trials in the midst of this BA.5 surge.
So this whole issue of rebounding, help people understand, what does that mean exactly? And are they contagious?
Right.
You know, can they pass it on if they have this kind of recurrence in a negative test like the president is experiencing?
And so absolutely, I want to emphasize that people are very contagious during a rebound. That means the virus really has resurged. And people have to begin their isolation over again, back to 5 days of quarantine, trying to test afterwards to make certain you have a negative test. So I really can't overemphasize enough that if you rebound, in other words, if you had a negative test after taking Paxlovid and now either have a recurrence of your symptoms or a positive Paxlovid test, you must re-isolate. You are contagious again.
Would it still be your recommendation that people consider Paxlovid still as a viable option of treatment if you test positive, if you test positive and you have symptoms?
You know, I think when we look at the trials that have recently been applied just in the last couple of days to the FDA, this EPIC HR high risk, EPIC SR standard risk, certainly it looks as if there was at least an 84% relative risk reduction in hospitalizations and death, even in lieu of this Omicron surge with this BA.5. What we don't know exactly is what that rebound will be, but certainly we see people being kept out of the hospital, and certainly we see a mitigation of those symptoms. And so while we continue to battle these variants as they emerge, Paxlovid still is a very significant part of our armamentarium.
Okay. Now I want to turn now to the monkeypox outbreak. New York City is now the second major city to declare a health emergency over the outbreak. Do you think that there are going to be other cities that follow suit, like New York is experiencing, and San Francisco?
Monkeypox is a great example that we still don't yet understand the scope, the depth, and the breadth of this infection, how widespread it is. We certainly see it predominantly taking hold in the community of men having sex with men, and also bisexual men. But surely it will creep into the rest of society. This is where the monkeypox virus has found its foothold, mostly because of sexual practices. But it does not mean that it is only confined and defined by this community. So we really have to get a hold of it. We certainly do not want twin pandemics where we are battling monkeypox virus. We're still battling the COVID pandemic. Hopefully lessons learned from COVID can be applied practically to this monkeypox virus. We must do contact surveillance, sometimes difficult, and anonymous partners, and make certain that everybody who has access can be vaccinated, and not just those people at risk. And I think that's what we're seeing in New York as these cases continue to climb.
You're a physician here in Atlanta. Is Atlanta ready? Are all the tools available to respond to monkeypox here?
And really no place in the world is really ready. We are not ready for these viruses that are coming aboard. We are quickly scrambling. We see laboratories now becoming available where early on we really didn't even have the ability to test for monkeypox reliably. We have certainly gotten that in place. We now have vaccines being ramped up. Previously, our stores really were for military and for healthcare workers who work in laboratories and directly working with the monkeypox virus. So we're seeing that ramp up as well. Smallpox vaccine can be 80 to 85% effective in people with monkeypox because they are both a part of this orthopox virus family. And so all of these tools should be at our disposal. The good news is that even though demand is outstripping supply, that's excellent news because people are seeking it and looking for it. And we had such a struggle during our COVID pandemic of having people step up to receive this vaccine, such a big campaign. Now we see people asking for it, requesting it, and we need to be able to meet that demand. But no, we are not there yet.
All right, Dr. Jane Morgan, good to see you.
Thank you.
Thanks so much.
Thank you.